When many of us in clinical medicine think back to our own training years, we often recall interacting with master clinicians who were skilled diagnosticians, thoughtful teachers, and role models of a compassionate bedside manner. What lessons do these master clinicians have to teach the rest of us in terms of how they learn, how their minds work, and how they became so good at what they do? I'm Vivek Murthy. Welcome to the Master Clinician Project. What follows is an interview with Dr. Monica Gandhi. Dr. Gandhi is an infectious disease specialist and an expert in the comprehensive care of patients who have HIV. She's professor of medicine at the University of California, San Francisco, and associate chief of the Division of HIV, Infectious Diseases, and Global Medicine at the Zuckerberg San Francisco General Hospital. She's the director of the UCSF Center for AIDS Research, medical director of the HIV clinic at the historic San Francisco General Ward 86, and associate director of the ID Fellowship here. She earned her MD at Harvard Medical School, MPH at UC Berkeley, and completed medicine residency and infectious disease fellowship at UCSF. In addition to her clinical expertise and numerous leadership roles, Dr. Gandhi is a prolific scientist and investigator in the field of HIV research. She's also the recipient of numerous awards celebrating her excellence as a teacher and mentor for medical trainees, as well as her humanism as a dedicated clinician and patient advocate. She was elected to the UCSF Council of Master Clinicians in 2019. In this conversation, Dr. Gandhi talks about the formative personality traits and learning habits that have been with her throughout her career. She talks about compassion, seeing patients as more complex than the decisions they make, and putting politics aside in our clinical work. She describes her clinical role models and shares the early life experiences that instilled in her a commitment to social justice and led her into the field of HIV medicine. What emerges from our conversation are clinical pearls, life lessons, plenty of inspiration, and a portrait of Dr. Gandhi as an exemplary physician and compassionate role model who has lessons to teach all of us. I hope you find this conversation as illuminating and inspiring as I did. Dr. Gandhi, thanks so much for joining us on the podcast today. I'll start with a general question. As you look back at your early career, during and just after your medical training, do you think you had any specific personality traits, learning habits, or clinical behaviors early on that you think were helpful in growing your clinical expertise?
Yes, that's actually a great question because the reputation for infectious diseases is that we're very detail-oriented and can spend quite a long time discussing one drug. And that was always me from the very beginning, just from childhood, just pretty detail-oriented and pretty listy about how I would learn. And so I think it kind of it was clear that I was going in this direction of this particular specialty. So that really makes sense to me that I went into infectious disease.
Detail-oriented, got it. Anything else? Any other traits or habits or behaviors that you think were foundational for you?
You know, I grew up in Utah, which was, I'm Indian American, and it was pretty difficult at times because there was a dominant culture and a dominant religion at the time. It's really changed now, and I didn't feel, part of that. And so there was a lot of kind of aspects of my personality that grew up in a way thinking very deeply about what it feels like to belong and what it feels like to not feel like you belong, and being stigmatized for something that you can't control, like your color of your skin. And I thought a lot about social justice. And because of that, for me, and there are many fields like this, but infectious disease and HIV especially is really one of social justice. So is COVID-19. So is any infectious disease pandemic, because it's not even that it's that complicated. We could actually prevent and treat an infectious disease. It's a lot less complicated, in my opinion, than rheumatology or oncology, where it's your own body and how to treat that. So there's a lot that goes into infectious disease, I think, that is about equity and social determinants of health. And I was very interested in that because I had a formative experience growing up feeling really different, I guess. And so I do think that that shaped my interest in HIV and in infectious disease.
Do you think that early perception of difference, which you're describing, influenced your clinical approach or your identity as a physician?
Yes, I mean, it really does actually, because something happened to me in the face of feeling different and judged, which was that I actually, one thing I can safely say for myself is I don't have a judgment towards people based on, I don't feel that I do. I feel like any behavior that anyone's working on in terms of their health behavior, so smoking or sexual activity or COVID-19 risk, or sheltering in place, or there's just a number of things where there are many aspects that go into someone's risk of contracting a pathogen. And it's not just that one thing. It's not just, well, don't have sex, or, well, don't go out and work, stay at home, or, don't smoke. Like, it just feels like it's much more complex than that. And I do think that I do approach each patient's circumstances very individually. I'm very, very lucky that I get to be a primary care physician and not just a specialty physician, because part of being an infectious disease HIV doctor is I have known my patients for like 25 years. And so I've seen them grow from not taking their medications every day, and there were long periods of non-adherence, to like now they're perfect. And I got to see that it was circumstantial and it wasn't about judgment. So yes, I think there's no doubt that I got really influenced by my upbringing and what I wanted to do and how I wanted to treat patients.
Well, it sounds like that perception of difference early on, which was a difficult experience, was transmuted into empathy and a sense of understanding of others as more complicated than one or two decisions that they make.
Yes, even though I it was really difficult, and I'm glad it's way in my past. But yes, exactly, it was hard actually.
I'd like to ask about your early career learning efforts. You mentioned being meticulous. I think you said a list maker. Do you think you had any other learning habits or techniques that were specific to you, which you've carried with you for a long time?
I actually think I have grown in my learning. So used to think that you would learn through copying things and taking meticulous notes and memorizing and just remembering. And it made me actually a micromanager when I was a second year resident with first year interns. And I'm sure they just liked me very much. And then it probably went on in time where, as I was a new attending, I wasn't good enough about like letting go. And now, actually, I have grown from needing to look up everything myself, needing to be that meticulous list maker, checking everything twice, to more big picture. And so, actually, we talk about this with personality traits, that you're not supposedly don't change your personality. I think that's not accurate. As you grow up as a clinician, I think if you stay in the mode, especially in a teaching hospital where you have to see the value yourself to like verify it, then you're stuck, and you've also a horrible teacher. So I think I've actually changed from that level of meticulousness and have zoomed out, actually, and that is growing up. I think, as a clinician. So I was different at every stage of learning.
And how about your clinical behaviors and practices? Do you think you had any clinical approaches during your training and early faculty years that were foundational for you that have followed you since?
Yes, I mean, actually, I'll never forget this, but the first patient I ever saw, and this was as a first year medical student, and we were supposed to go into, like, in this case, it was Brigham and Women's Hospital, and I was supposed to interview a patient who had been admitted. We were supposed to do a social history about how do you like when, he was actually from Ethiopia originally, and how did you like coming to this country, and do you smoke, and do you do this? And he had an accident when he came to this country, and he was paralyzed from essentially mid-torso down. And I couldn't actually ask those questions, and actually I couldn't stop crying, because the reason was it felt so artificial to ask him these questions when his whole experience had changed because of his accident. And now everything was about medical care when things were so different. And I have one thing that I can say safely is I have cried, and maybe I'm just a crier actually, but I have cried multiple times with patients. And I have said sorry so many times, though, I think just saying, I mean, I've been thinking about that with public health messaging with COVID. Like before you put another restriction in place, just say, I'm so sorry to someone. Because I think it's amazing how doctors and clinicians learn how to, we're supposed to like learn empathy, and we learn these words like, that must be hard for you, and that sounds really rote. But like you could just sit with someone and you know that you can't move on with the next step unless you just literally acknowledge how awful it is that they had this accident, or that they have this cancer, or that they just got a new diagnosis with HIV, or it is just so hard. And so, I think if that's a technique, I have to say, I tend to cheer up a lot with patients because I feel a lot of, I just want, like I started with a lot of sorry, and then we go into like what antiretrovirals to take.
I think that's a really powerful and actionable strategy. More than empathy alone, truly sharing in someone's sorrow and genuinely acknowledging the difficulties in their life, taking the time to do that. It shows people that we care about them in a fundamental way. And then the other aspects of what we do, labs, scans, prescriptions, referrals, can grow from there.
They
Right.
will, yeah. And I think, well, I'm sure we all genuinely feel it. It's actually partially why we put up walls, I think, as clinicians. We're like the really unfortunate patient in room 3. But if you, and that's a wall that we're putting up, but literally just like anyone in a community would say to you, I am so sorry you got this new diagnosis. This must feel really hard. And then you start with that, right? And then you say, and you'll have a normal lifespan. I swear I can give you antiretrovirals that you won't have any side effects with. But just start with that. We've been doing these rapid antiretroviral programs, giving people medications on the first day of HIV diagnosis. And we did some qualitative interviews recently, and that's what someone said. They said, I totally get they're going to save my life, and like it's totally okay to have HIV and I'm going to be okay. But just first say, this is not the diagnosis I wanted today, and it was really hard.
I think that's a great practice for all of us. Being empathetic and understanding and showing patients that our heart is there with them as early as possible at the very first interaction. My next question relates to discovering a field within medicine that you're passionate about early on in your career and translating what inspires and drives you to what you do in your daily clinical work. To our listeners out there who are meeting you for the first time, you're a globally recognized expert in HIV medicine. How did you choose this subspecialty within the field of ID? Were there any specific experiences or patients you can recall that inspired you to focus on this field?
I think two things happened that inspired me to go specifically into HIV within the field of infectious diseases, which is, one is that when I, again, growing up in Utah, I did have a friend who was gay and came out to his parents when he was 16, and it was the middle of winter and he was asked to leave the house. It struck me in the same way that I felt, that I was Indian growing up in a relatively white place, that like he was completely, told not to be just what he was. And so that experience really stayed with me a lot about stigmatization and homophobia. And then the second was that I happened to be in medical school when, like at the very beginning, when we were figuring out that a virus, this particular virus at least, can't be treated with one antiviral because its polymerase is so leaky and it has to be hemmed in on multiple sides. And we had a lecture in medical school, and I thought, this is never actually going to be so easy as to just give something to cure it. This is going to be a long-standing process between patient and provider on their treatment, because you can't just give one drug. Somehow it struck me that I wanted to have those conversations with people over a lifetime. Like I want to know them well enough so that I can know why a certain medication they didn't like. And it struck me that I could be a primary care physician and a specialist at the same time, which I know is true in rheumatology and other specialties. And I wanted that a lot because I didn't actually want to be a jack of all trades. And I was much better at knowing one thing really well, but still getting to be someone's primary care doctor. So I think those are the two most formative experiences, along with the social justice aspect, because the history of HIV is so fascinating. And it's like, I just think HIV, from its very basic biology that it integrates into your chromosome, I mean, it's crazy, to its history and how it entered human populations, to its political justice, to its advocacy, to patients coming in to like hand in hand, standing in front of the FDA and like protesting together. Like HIV is interesting from every point of view. It is so holistic. And so, yeah, it has been an absolute privilege to have like gotten those sparks about it at the beginning, and now to be an HIV doctor. Like I literally am so lucky. I love working in HIV. I really can't express enough how passionate I am about it.
I'm hearing that you had many early life and medical school experiences which span the social justice and technical dimensions of HIV medicine, which called you into that field. Can you remember any other experiences caring for patients who had HIV during your training years or early career, which confirmed to you that this was indeed your calling?
Yes, it was actually more in residency because I really made as fast as a run as I could in a way to San Francisco for my residency, and I really wanted to be at UCSF because of my interest in HIV. And it was during residency that I met someone who was in the hospital, because that's where you see patients a lot, who, as opposed to the outpatient setting. And he had gone all the way to a brain biopsy because he was very careful about keeping a particular risk factor he had for HIV hidden. No one thought to ask, understandably, because he was also keeping that very hidden. And so he went to a brain biopsy, ended up getting diagnosed with HIV from a brain biopsy of ongoing neurological complaints, and someone like literally noticed that there was HIV in his brain. You can see these certain patterns. And then someone asked the question, have you ever had any, risks? And he had sex with men. And so it was one of the most formative experiences, because it was kind of like we were all just in our boxes kind of thinking, well, this person doesn't have HIV, this person doesn't have HIV, this is a risk factor based disease, and it's not routine, and especially in the 90s. And by 1996, the CDC had put out their guidelines that said, do not think of it as a risk-based infection. Think of HIV and screening for it routinely. And that was 1996. And we're still to this day in 2021 still asking each other, like, should I even do an HIV test? Like, it's very interesting to me, that kind of entrenched thing that there are certain people who would get HIV and some wouldn't. And that was profoundly formative. So I will always remember him. And then I actually didn't have that much medical knowledge when I was a resident at all about antiretrovirals. So I would just sit with people and talk about their stories, but I didn't have that medical knowledge. And it made me desperately to want to be the person who knew like every aspect of an antiretroviral. And I was an intern at San Francisco General in 1996, before the very highly potent antiretroviral therapies were quite there, or quite like approved, or quite in place. So 40% of our patients that were admitted to the inpatient medicine wards had AIDS. And then later, literally by, maybe the end of the year, we had seen people rise from the dead. I mean, literally, it was Lazarus. It was like watching these highly potent antiretrovirals and NRTIs and protease inhibitors come into play. And you could see that massive change over 1 year. And you're tired and totally an intern. And it was so incredibly formative. So that led me to be very moved. I was just moved. I was moved by progress in medical science. I was moved by what you could do if you put, that you can change something to a chronic disease like HIV. And being with COVID, it has been moving and incredibly interesting, despite all the politics, to actually see the amount of progress that was made in such a short period of time. Like, take all that progress that was made in HIV over 12 years and compress it into 9 months for a vaccine. It's sort of so stunning. And the vaccine just came out today, and I think they just vaccinated the first person in the United States this very day. They just showed her on the news, a nurse in New York. It is so stunning and so amazing to be part of it. It wanted me. I wanted to be in a field that infectious disease, and I really don't know how you rheumatologists and oncologists do it. I have to give you credit. Infectious disease, a pathogen looks different than the host. It's really quite different. Because of that, we can get there with treatments or with vaccines. And I think it's much harder when the body is changing. So I chose an easier specialty than you did. But yeah, it was formative to be in the beginning of HIV, and it's formative for all of us to be watching COVID unroll in front of us.
Listening to your experiences as an intern, when you saw that difference in antiretroviral treatment efficacy from the start of your intern year to the end, as science marched forward before your very eyes, is incredible. I think what's probably implied there is that you had to read a lot to keep up with the dramatic changes in therapies that were coming out. You must have had to read so much to keep up. Do you feel that going through your training during those dynamic years of the HIV epidemic influenced any lasting learning habits or clinical behaviors?
Yes, I think it's imperative to going back to that detail oriented, to kind of know everything about one thing. So I wanted to know everything about HIV. Like, I didn't want to be, I do read. I read a lot, and I keep up with literature a lot with HIV, and I look at every conference book and think about it a lot. But I was not capable of doing that with a broad range of topics. I wanted to be super specialized in one thing, but also be the person that knows a lot about that thing, as opposed to kind of knowing a broad swath of information. So yeah, I think HIV, in a way, it honed that I wanted to be super detail oriented, but I wanted to do about one thing.
And do you think that if you'd trained during a period of time where care for patients with HIV was less dynamic, not changing as much from month to month, do you think that something would have been lost in terms of your learning program or your diligence with reading? In other words, do you think that because you trained when you did at UCSF during those years, you developed certain reading habits or diligence in learning? Or do you feel that you would have developed those practices regardless of where and when you trained?
No, I think the question that you just asked is a great question, and I think that's absolutely right. It almost became your moral duty if something is changing so fast, and a tweak between knowing the differences, every single nuance between efavirenz and nevirapine would change someone's course of their next 5 years, which one had a slightly higher genetic barrier to resistance or what they could tolerate. I think it shaped me in having a moral imperative to know everything about it. Because those medications were really hard to take at the time, it was really important for me to know every nuance. I keep on thinking about this with anyone who's in medicine right now with COVID-19, because it's such an amazing dynamic thing over this last year. I can't imagine that this last year isn't going to be one of the most shaping experiences in every clinician's life, especially if they're younger. Because if you're more junior, this is so shaping, and then it will set your habits. And so I do think that's why more people are applying to medical school and more people are applying to ID. Like, this is riveting to get your habits set on learning by something new. And that's what happened to me with HIV.
I think those similarities between then and now are really powerful. And it summarizes that kind of culminating energy that flows through our professional ranks as we're drawn together to confront a shared challenge to health on a national level. So I thank you for connecting the past with the present. My next question has to do with the concept of role models in medicine. I've always been fascinated by the idea that in order to become good at something, it's important to have a detailed conception or a mental model of what great performance in that field looks like. For example, I grew up playing the saxophone, and my music teacher always used to emphasize the term jazz conception to suggest that in order to become a better musician, I really needed to listen to more great jazz to internalize what that sounded like, to give myself an index against which my current performance could be measured and analyzed and improved towards. It comes back to that idea that one needs to develop a sophisticated mental model of what greatness looks like before one can become great. Do you think that's true in clinical practice? And did you have any specific role models who might have helped you conceptualize the professional development you wanted to see in yourself?
I think that is a great example, what you just gave about music, because I was drawn to two types of mentors and two types of models. One was sort of kind of unfathomable kindness. And what I mean by that is like those clinicians who kind of through their kindness, everyone wanted to be around them. And that provided really good leadership. They actually may not know every single aspect about every single thing, but there was something about that kindness that led to the opening up of the provider-patient relationship. And then the second that I was drawn to is rigid attention to detail and being so rigorous in that thinking that sometimes you won't let things go. And that actually seems like those are just two such opposite things, just like you have two parents or something that you want one to be one thing and you want another to be another. I was drawn to those types of personalities. And I have two examples in my life currently, actually, of a very detail-oriented mentor who I admire because you think that she's so high up that she just let things go, but she is so concerned about the patient. She's so concerned about something that she will pursue it. And I think she's incredibly rigorous. Then the other one is someone who actually has moved mountains just by the dint of his personality. And they're so different, but they both move me. And those are I'm drawn to those two extremes. And I found myself being really like the colleagues who are one of those two. That's how, I don't know, that's what impressed me. So those are the two people I want to be.
And during your training years or early career, were there any other approaches or behaviors that you took away from valued mentors that you've incorporated into your daily practice?
Yeah, I don't know why this really moved me so much, but actually my residency director, I don't think we do this anymore because of COVID, but he breathed on his stethoscope to make it warm, before he put it on the patient's chest. And we could do that differently maybe now with COVID, like maybe rub it or something. But I just thought it was such a gesture to do that ahead of time. And these gestures, like, are you warm enough or is that blanket thick enough? I don't know. I saw little gestures that really moved me in the context of the clinical experience. And I tried to take every single one of those gestures, like saying hello to a patient, if they're unconscious, you still say hello. You still tell them who you are in the hope and concern that they can hear you. And you ask before you lift someone's robe to listen. Just these are like tiny gestures that I watched people do, and they really impressed me. So I have been constantly learning about gestures and what they matter, to introduce yourself, to make things warm, to make things comfortable. I've learned so much over the last, from the very beginning, by watching people and then by watching what I don't like.
That's a powerful point you make, and one that resonates with my experiences as well. Maybe you could say that we're just a collection of the best that we see in others, and you never know what clinic, which consult, what day of the week you're going to see a glistening example of something wonderful. And you're like, I'm always going to do that.
And if I remember one gesture by one attending like 30 years ago, then I wonder what our trainees are remembering of us, as we gesture.
Exactly. I was a clinician educator and hospitalist for 4 years before coming back to UCSF for fellowship. And I always used to think, looking back at my life and seeing those fleeting and unexpected moments where someone inspired a certain habit or behavior in me forever, I'm always striving to hold my own actions as a teacher to that standard, because you never know what single moment for you will reverberate for someone else for decades. It's really a reminder that we need to strive to be the best versions of ourselves as often as we can be.
But it will flash into their minds many years later and they'll do that same gesture. And I think, it's amazing.
My next question has to do with administrative work. You hold many leadership and administrative positions here at UCSF. For example, you're the director of the UCSF Center for AIDS Research, medical director of the HIV clinic at the historic Ward 86, co-director of the HIV/ID consult service at the Zuckerberg San Francisco General Hospital, and you're also associate director of the ID fellowship here. All of this implies that you must have exceptional time management skills. And during all this, you still remain a recognized expert in the clinical care of patients with HIV. So for the medical trainees and junior physicians out there who are listening, do you view administrative duties as competing for your time in terms of being able to practice and grow your expertise? Or Is there a point in your career where the clinical foundation is so good that the time diverted towards administrative duties is no longer so much of a trade-off? Or, a third option, I guess, would be, paradoxically, do you feel that some administrative duties can actually contribute to one's clinical abilities?
I think that's an excellent question, and I actually like of your three options the latter, which is that your administrative work should make you a better clinician, and also you want to, I think, through your administrative work, model really good clinical behavior. So what I mean by that is I get to set standards of care at Ward 86 because I'm the director that are firmly based in what I would do like in a patient interaction. Like we can't forget DEXAs in our patients with HIV because of different things with the bones and tenofovir. But so it's like I get to set policies, I think, that have more more widespread implications for the clinical care of patients. And then I get to write up those policies, and then that will have widespread implications for other clinics that may look to our clinic as an expert. So I actually think it should inform your clinical care, but I also would very much say that I don't think that anyone should abandon clinical medicine. Like, you may have to cut down on clinical medicine for sure, but to be a truly effective, I think, administrator, unless you're doing something purely research or something like purely in a lab, as much as you can, please keep your hat in the ring of doing clinical care. I know some people will just get away from it completely, but I would wither away if I didn't get to do some clinical work. So I have cut down, but I have to see patients every week, and I have to do inpatient attending as many weeks as I can.
I have one last question for you today, which has to do with current events and the COVID pandemic. This has been an impossibly difficult year for everyone, including medical trainees. Do you have any advice for the trainees or junior faculty out there who are either directly caring for patients with COVID or carrying on with their usual work in the face of the pandemic?
Yes, I think this is a great question to end with. And I think what HIV taught me is meeting people in a way that understands that they may have other things in their life besides avoiding the risk of a pathogen, like we talked about before, like more harm reduction. And so when you are treating someone who did not mask or does not believe in social distancing or does not think that coronavirus is real, you have to bring all of your compassion to that interaction. Our politics cannot get in the way of being true healers. We treat people who don't mask, and we treat people who mask. And beyond that, when you counsel someone, this kind of stigmatization that we have a little bit in our messaging. I have been so surprised by watching public health practitioners because they were so angry at the federal administration not use language that I would expect a doctor to use. And so it is going back to meeting someone where they are, harm reduction, understanding that they have other things in their lives. They actually wanted to see their mother for Thanksgiving. It's really okay. And, I don't know, like I have been shocked by how politics have influenced some of the ways that doctors and healers are talking. And that is not our role. Our role is literally just you and me in a room when I'm taking care of a patient, and that human experience of that patient, and has nothing to do with their politics. So that would be the thing I'd want to end with, is that HIV has done that for a long time. Addiction medicine's done that. Cardiologists do that. They don't say, I can't believe you ate ice cream. They said, let's bring down the risks of unhealthy eating. It's everything has to be about compassion.
I really appreciate that lesson, and I think our listeners will too. I think it actually goes back to how we started this interview, which was emphasizing that understanding and compassion come first, and that everything else flows from there. Dr. Gandhi, thank you again for your time and your insights today. I hope you enjoyed this episode of the Master Clinician Project, featuring the truly great Dr. Monica Gandhi. You can find us online at www.masterclinicianproject.com, on Twitter at MCProject12, or as an audio-only podcast on Spotify or really anywhere you listen to podcasts. Thanks for joining us as we endeavor to learn from the very best clinicians. See you next time.